Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Any healthcare professional's first duty is to the patient, and they should do whatever it takes to assist that patient, either themselves or by referring to someone else who can help.
Welcome to The Health Advocates, a podcast that breaks down the major health news of the week to help you make sense of it all. I'm Steven Newmark, Director of Policy at the Global Healthy Living Foundation.
And I'm Zoe Rothblatt, Associate Director of Community Outreach at GHLF.
Our goal is to help you understand what's happening in the healthcare world to help you make informed decisions to live your best life. But before we get started, we want to be sure that everyone takes a listen to all of GHLF's great podcasts. We have so many to choose from.
We sure do. As a reminder, you can check all of our podcasts out at ghlf.org/listen. This week, we'll give a shout out to the podcast called Thriving While Aching. It's hosted by clinical psychologist Lori Ferguson, and it really just showcases the stories of older adults doing what they love despite aches and pains.
That sounds like my life, so it's great that Lori's doing that.
Okay, let's start with a listener comment. Ready?
I am ready.
This one is from Jack M., who wrote, "I enjoy tuning in weekly to learn from you." Thank you so much.
Today we have a special guest with us, Dr. Donald Miller, Professor of Pharmacy Practice at North Dakota State University and former member of the FDA's Arthritis Advisory Committee. And he is here to talk to us about how pharmacists play a role in patient advocacy and share thoughts on the Methotrexate access issue that we've been discussing.
But first, we do have a few news updates. There was a lot of COVID-related stuff this week. Perhaps the biggest one is that the CDC loosened the COVID guidance.
The CDC estimates that 95% of Americans ages 16 and older have acquired some level of immunity, either from being vaccinated or infected. And as such, they have loosened their recommendations.
Yeah, there's 5 big points. The first one is test to stay is no longer recommended in schools. This was used by schools to allow students who were in close contact with a person who had COVID to continue to attend in person as long as they've been testing negative and asymptomatic.
It sounds almost like it's more akin to traditional illness, such as a flu or a cold. The new guidelines say stay at home for 5 days, followed by 5 days of masking on return. The significant change here is that the last set of guidelines suggested that schools required the test. The guidelines continue to suggest the use of a test-based strategy if masking is not possible.
And I think in general, this updated guidance shows that, it's really focused on the individual now as we continue to live with COVID. The second point here is that unvaccinated people no longer have to quarantine if they were exposed to someone with COVID.
I guess I wouldn't even say selfish. I would be of the mindset that, hey, if somebody in your family has the flu, I would kind of prefer you stay home, frankly, than come to my office. And if you are going to come to my office, I kind of would prefer you wear an N95 mask while you're here. I also do understand that that has not been what we have done with other viruses ever. So we're sort of falling back.
It's important to note the third point here is isolation is still recommended for people with COVID. So what we were just talking about is exposure, but if you test positive, you still do need to isolate for at least 5 days.
Absolutely. And again, comparing it to flu, I would hope the same is true if someone gets a flu.
Yeah, rest, lots of fluids, stay home.
And stay the heck away from me.
Yeah. Stay away from our immunocompromised community, please.
Yes.
Respect us.
Yes. Well, back to testing. People with COVID, the CDC now says you need 2 negative tests within 48 hours. If you have had COVID and are isolating before going back out in public, 2 negative tests within 48 hours.
And then the last part of this is the CDC, I guess, dropped the 6-foot standard. They're making social distancing less of a priority now as we move forward.
Which makes sense. I am a little embarrassed. I didn't even realize we were still doing the 6-foot standard. I thought it was reduced at some point to 3 feet. I thought I remember reading that.
No, I think that was last summer, I remember.
We've said it before on our podcast. It's up to yourself as an individual to stay as protected as you can, which puts the onus on you to wear the proper mask and make sure it fits properly and all of that. What I find tough about this is when I am out in public, in an indoor setting, on mass transit, I am wearing an N95 mask at all times. But there's a part of me that wants to sort of take a breath, like pull the mask down and take a breather here and there, as is the norm when you have these masks. And I feel very uncomfortable even taking that breath because very few people are in masks anymore. I would feel more comfortable if everyone was wearing a cloth mask or one of those disposable. I feel like at least there's some level of protection from the virus, from something leaving that individual's nose or mouth by having some kind of covering there. And I could allow myself to take a breath here and there.
I think you just summed up pretty well, like how a lot of our community is feeling, like just very alone in it, and not like it's the community is in it together. Maybe the chronic illness community is in it together, but the community at large is sort of ignoring the needs of people who are high risk. And while I will say that, COVID in 2022 is very different than COVID in 2020, and we know a lot, and we have vaccines, we have protection, it still is scary for our community.
I will say one positive thing that I find, I know it depends where you live in this country. I have found that wearing a mask, I don't see anyone giving me the side eye, anyone shaming me, anyone looking askance because of the mask.
Yeah, I'll tell our listeners, I recently moved to Tennessee, and I feel like I'm 1 in 5 people that wears a mask here. And while I don't get mask shamed at all, I definitely do get some side glances like, whoa, you're still wearing that thing? And it definitely is different than New York City, where I think more people are in masks. It's definitely dropped down, but here especially, I'm like one of the only people, and it almost feels embarrassing at times. Like, oh, why am I still doing this? I'm the sick kid. And I just have to remind myself why I am doing it and that I'm staying safe and protecting myself. And I don't want to catch COVID just because I want to get groceries. Like, it's very simple to just keep myself safe. Going back to some of the guidance, the CDC recommended 2 negative tests. I saw that the FDA had actually recently recommended to do 3 take-home tests if you're exposed to COVID.
Previously, the FDA had advised taking 2 rapid antigen tests over 2 or 3 days to rule out infection, but now they're saying 3. They say new studies suggest that just 2 tests can miss many infections and result in a spread to others, so adding a 3rd test will improve accuracy.
And then our last round of, COVID news, the FDA accelerated the release of the next round of COVID boosters.
These are going to be distributed in September, and the new shots are being reformulated to include components of the Omicron strains BA4 and BA5.
I'm curious to see how the CDC updates its vaccine guidance. What shot is this considered, and is it considered different than the others? I'm curious to see how it goes because many in our community just got a 5th COVID shot.
It should be noted that this vaccine also includes the original strain in addition to the Omicron strains. The thing that I'm curious about, because there's so much less testing going on now, public testing at least, I can't figure out how prevalent BA4 and BA5 are.
Totally, because so many people also just do the at-home test, and then they'll just stay home with a mild infection and do what they need to do, but it's not reported. And many people are just not testing at all if it's so mild.
For now, we turn to our special guest here with us today, Dr. Donald Miller. He's a professor of pharmacy practice at North Dakota State University and former member of the FDA Arthritis Committee.
Welcome, Dr. Miller. Thank you for joining the Health Advocates.
Hi, thanks for having me.
We've been working a lot, Zoe and I and our colleagues at GHLF, regarding the Methotrexate access issue in the wake of the Dobbs Supreme Court decision. How are pharmacists handling this access issue, and what have you been hearing generally?
It's a very important question. At first, I think pharmacists were really confused about what to do if they lived in a state that was banning abortion. The problem has really come around methotrexate, because that is listed by some states as a drug that's used for abortion. It's a bit of a misnomer because it's not used for typical abortion or medication abortion. It is used sometimes in ectopic pregnancy. An ectopic pregnancy, by definition, is not viable, will threaten the life of the mother, and has to be removed. So it's not done by surgery, it's done by medication. So that is really a drug that should have an exception for abortion. But nonetheless, obviously, many people are afraid of getting accused of being involved in abortion, being afraid of going to jail. Even the accusation could be fairly devastating. So a lot of pharmacists are very careful, and at first we're turning down prescriptions for methotrexate altogether. Most methotrexate is for rheumatoid arthritis and other rheumatic diseases. So if the pharmacist knows the patient or knows the prescriber, it should not ever be an issue. I can see if a brand new patient with a different doctor came in with a prescription, the pharmacist would have to ask questions, clarify appropriateness. That's perfectly okay. But in fact, if it was being prescribed for ectopic pregnancy, then that actually should be okay too. Again, the legal environment has to get sorted out here. There are two important issues. One is the pharmacist, of course, can turn down a prescription. They can do that because the prescription is inappropriate, or they can do it because their conscience won't allow them to do that. So, some pharmacists don't want to prescribe morning after pills like Plan B. So that's fine. If a pharmacist is declining because of their own conscience, then they need to make arrangements for another pharmacist to fill that prescription, either in their pharmacy or a different pharmacy. But at the same time, they have an obligation to the patient. So again, if they want to decline and yet the prescription is appropriate, they have that obligation to help the patient.
In a scenario like this where a patient is having trouble accessing their medication, whether it be this methotrexate issue or all the time there's different barriers that are, stopping patients from access their treatment, whether it's insurance barriers, shortages, what types of actions can pharmacists take to help patients in scenarios like those?
You mentioned insurance access. That's a huge issue and time consumer for pharmacists. Both physicians and pharmacists will spend a lot of time trying to navigate insurance. There are many issues with something not being covered, or insurance companies may require a patient to fail other medications before they can get a more expensive drug. It's inconvenient for the pharmacist, but any healthcare professional's first duty is to the patient, and they should do whatever it takes to assist that patient, either themselves or by referring to someone else who can help in a better way.
Can you tell us about any action that pharmacists can take to help patients become better advocates themselves?
When you say advocacy, I always think of legislative advocacy, which is something also I've been involved in. Here is an issue where I think patients and healthcare professionals need to get involved, particularly right now with state legislators, where states are banning abortion or have severe restrictions. It needs to be clarified that there are some safe harbors for prescribing medicines like methotrexate. So that's going to happen naturally, but I think if pharmacists and health professionals in particular can be very helpful to state legislators to say, here's some ideas for how you can clarify things, give us some legal safe harbor, and yet maintain some restrictions.
Switching gears a little bit, you're a former member of the FDA Arthritis Advisory Committee. Could you tell us about what that committee does, why it's in place, and what your role has been as part of it?
By law, the FDA has a number of advisory committees in different therapeutic areas that they'll convene when they're considering a new drug application or a change in a new drug application that is not straightforward. The FDA is not monolithic. There are many people involved in making a drug approval decision. It's very clear when you're on the advisory committee that sometimes there's arguments within the FDA whether to approve or not approve, what kind of labeling would go along with that. So when an advisory committee is convened, it's usually a day-long meeting. The drug manufacturer typically will present their case first. They'll give all the evidence they can saying, yes, you should approve this medication. Then the FDA will kind of give their point of view, and they'll point out any concerns they have about either safety or efficacy. There's always a time for any interested party, like patients, to make comments. And then there'll be just an open discussion on the issues, and that'll be finalized eventually with a vote for approval. The FDA usually follows the advisory committee, especially if it's sort of a slam dunk decision. But sometimes even the advisory committee can be conflicted. If it's a 7-6 vote in favor or against approval, it doesn't necessarily give the FDA clear indication. But even if the vote is pretty clear, I've found that the FDA convenes these meetings to get opinions. The FDA staff, of course, are not in active practice anymore. And so when you have practitioners on that advisory panel, they can say, well, in my experience, this is what I think might happen, how the drug might be used. And that really gives the FDA a lot more insight into whether to approve and also the conditions of approval, the labeling that would go along with that.
You mentioned that patients are invited to speak up during these meetings. What's it like hearing from a patient? How does it differ than hearing from the other stakeholders? And do you think that the patient voice does make a difference?
It's good getting patients' unique opinions about what the drug did for them. Mostly consider the scientific evidence, but the patient's opinion also is useful.
This is great information for patients to learn about becoming better advocates and different avenues where patients can advocate, such as at the FDA. I know it's something that both Zoe and I have done on behalf of patients through our work here at GHLF. Also, it's great talking to you to hear about the work that you're doing on the methotrexate access issue and what you're hearing from fellow pharmacists. It has been invaluable for us to have this conversation. So thank you for your time.
Thank you so much for joining us and giving an insight into, behind the scenes at the FDA and what pharmacists are talking about.
Well, thank you very much.
Okay, Steven, that brings us to the close of our show. What did you learn about today?
I learned from Dr. Miller the importance of pharmacists in patient advocacy and the unique role that pharmacists can play in the healthcare ecosystem.
And I learned from you about the removal of the test to stay strategies in school as kids go back to school.
Well, we hope that you learned something too. We'd love to hear from you what you're dealing with as the CDC guidance changes. Send your email to thehealthadvocates@ghlf.org, or better yet, include a short video or audio clip.
And who knows, whatever you share may be included in our listener feedback portion of future episodes.
Also email us if you want to subscribe to our weekly newsletter, where we share the top health news of the week.
Thanks for listening to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. If you like this episode, give us a rating and write a review on Apple Podcasts, and hit that subscribe button wherever you listen so you never miss an episode. I'm Zoe Rothblatt.
I'm Steven Newmark. We'll see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.